like to invite Dr. Arco to come up to the podium and the stage, and so we're going to go ahead and start the next session. And if you could tee up my slides, please. So, again, over the past couple of days, you've seen a lot of cutting-edge technologies and all these amazing tricks and tools and atherectomy and all these amazing things that you can do, which is wonderful. But just like access and closure, the last thing you want is to do an amazing intervention, to spend 2 or 3 hours in revascularizing a chronic total occlusion and end up with a grow and bleed, a pseudoaneurysm, distal embolization, something that requires the patient to go on to an amputation. And so this session from what I'm going to be presenting is going to be complications, specifically distal embolization, and how to get out of trouble. Any luck with our slides? Wonderful. So percutaneous treatment of thrombus and emboli. So this will happen. If it hasn't happened to you already, at some point it will happen. And it will result in acute limb ischemia. Acute limb ischemia is defined as a sudden occlusion of an artery causing ischemia to the lower extremity. And this can be devastating, and it can result in limb loss, and even worse, it will present with pulselessness, pallor, all these, the 5 Ps, paresthesia, paralysis. What I'm going to focus on is, more than anything, the periprocedural complications. So acute limb ischemia can be caused by arrhythmia, distal embolization from atrial fibrillation, which is usually the most common. Periprocedural distal embolization, mostly from atherectomy, but balloon stenting, anything can really cause distal embolization. We're also going to talk about it in bypass graft and covered stent thrombosis. In terms of thrombotic emboli, this can usually happen when you're dealing with stent grafts or bypass grafts that have a significant amount of thrombus. They're very heavily thrombus burden is usually located in these bypass grafts. They're usually due to either inflow or outflow mechanical obstruction. Sometimes it can be due to hypercoagulable state and suboptimal dosage of anticoagulation. There's multiple treatment options if you run into this problem. If you have an embolic event from revascularizing one of these lesions and you're pretty sure that it's thrombus, then you can either drip thrombolytic medications. You can use a power pulse technique with mechanical thrombectomy, and we've described this pretty extensively, and it works pretty well. You can use the Indigo device, the Penumbra device, to aspirate this debris. And you can go to surgical embolectomy as well, which is suboptimal because most of the time you can treat these percutaneously. So this is a situation where we had a occluded stent graft, as you can see, osteal occlusion and reconstituted the popliteal artery. And as I mentioned before, most of these are due to either an inflow or an outflow obstruction. After thrombolytic therapy, power pulse technique with 7.5 milligrams of TPA, you see that it's a very focal mechanical obstruction that caused this thrombotic process. So what happens is this gets so tight that thrombus forms here, and then thrombus continues to layer, and then the entire stent graft gets filled with thrombus. So as I described earlier, you can usually treat those with either a mechanical thrombectomy or TPA infusion. What's even more difficult, however, is treating atherosclerotic debris because it will not respond to antithrombotic medications. It is a debris that you really have to either suck out, stent it, you have to do something else to it, and you have to treat it a little bit differently. And it can also be very devastating. And again, like I said, last thing you need after doing a long, complex procedure, or even something straightforward, is to have a complication like that and sent to your patient to either surgical treatment or amputation. In this study, they did a very interesting thing. They looked at embolic signal at the pedal arteries, the same thing that they use to look at embolic debris that can take place with carotid stenting. Well, instead of looking at it in the brain, they looked at it in the foot. And they measured these signals at each stage of intervention. And they found that at every single stage, there was increased signal, embolic signal, from wire crossing to angioplasty to stenting to Silverhawk to laser. So you will have embolic events at every single stage. Some might be clinically significant, some may not. So there's a couple of ways that I deal with these. What I used to use is a filter. And what I would do is go past the debris. You have to be very careful with the wire. You have to be very careful with the filter. Deploy the filter, catch it, and then pull it back. And you can sometimes get some pretty good success with that. This is an example of that. It's an osteal SFA occlusion. And then there's some debris there in some disease in the popliteal artery as well. And you can see, actually, we had distal embolization. You see the popliteal artery is occluded. You see on the right or on the left-hand side here, we used a filter. We deployed that filter and then slowly pulled that back. And usually you need a trailblazer or some end-hole catheter sitting more proximally to capture that filter and recapture it and then pull it out. It's very important when you do that, don't completely collapse the filter into your catheter, because what can happen is sometimes you can squeeze that debris back out and cause even further distal embolization. The problem with this is you can push that debris even further. And that's where you run into a problem, is if you then send it even further downstream, down into the pedal arteries, then that's even a bigger issue. Then we started using the Penumbra Indigo system, and what this is basically a extraction catheter. It comes in two sizes, the 4 French and the 6 French, and it's an end-hole catheter that used to be used in the neuro space. This is where our much smarter colleagues used to use this in the brain and suck debris out when they had distal embolization. Dr. Arco is going to go over this a little bit more as well, sort of the history behind this device. So it comes with 3 different things within the system. There's the actual catheter itself, there's a separator, and then one of the most important things, which is the pump that comes with that, and we'll explain that in just a little bit. So these are the 2 different systems that it comes with. The SFA popliteal system it was treated with the Cat5, which is the larger lumen system, and that has a lumen size of 1.6. So as cardiologists, we use, the Pronto, Export, these things for coronaries, but they're really not big enough for peripheral intervention because they have a lumen size of 1 millimeter, not 1.67. The other nice thing about this is, you'd say, well, why can't I just use my Trailblazer or Quick Cross catheter? Well, this is not a tapered tip. It's an abrupt end to the tip, so it allows you to engage that thrombus or that plaque a little bit better. So it comes in the largest size of Cat5 for SFA and popliteal, and then the Cat3 for below-the-knee disease. And then it comes with this separator, and what this is basically it's a wire that has this tip right at the edge here, and what it does is you just go back and forth and you agitate. Works better for thrombus. I would use that for thrombus, not really for debris, but you just kind of agitate that thrombus as you're aspirating. Now, this is the most important part of this, because then you'd say, oh, well, you know what? I can do the same thing. I don't need the pump. I'll just use the device and just suck back on with the syringe. Well, it doesn't really work as well as using the actual pump, and this usually just comes with the system, and this is reusable canister. And what this does is it delivers a significant amount of aspiration, and it's a pure vacuum that is consistent. So, if you're aspirating back, you're going to get an initial vacuum, and then it's going to go down. So this doesn't do that. It's a consistent vacuum throughout the entire process. So where can you use the Indigo system? Where you have distal thrombotic events, especially atheroembolic events, when you have thrombotic distal embolization, but you can't give the patient thrombolytic agents, and where you need rapid revascularization, because this works very, very quickly. And there are some other devices on the market that you can use for this, I like this just because I'm comfortable with it, and it's a quick and easy device to set up. Now, if you need to go even further, let's say you accidentally do push it down in the foot, or something happens where you're working the pedal arteries, well, you can put the Cat5 into the Cat3 into the Cat5 and go even further downstream into the foot. So here's an instance of a patient that had an SFA occlusion, osteal SFA occlusion, as you can see, comes back in the popliteal artery, And here we had distal embolization. And you can see we did a distal injection because we had no flow. So we did distal embolization, and this is an abrupt occlusion, and very clearly I knew that this was an embolic debris because we were doing atherectomy in this situation. And so we delivered the wire, we put the catheter right to the area of debris, and you turn it on, and you just slowly go down past the wire, and then you slowly pull back, and then as you're pulling back, just continue to pull it all the way out. And then you'll actually see that debris either in your basket, or you'll see it. Sometimes you can actually capture it as it's coming out of the sheath, so just be very aware of that and make sure you aspirate back once you pull everything out. And so this is after one run. This is after going in one time, pulling back. You see that we captured the debris, and that's what it looked like afterwards after revascularization. And you see flow to the foot looked really good. I'm going to leave you with one other case. This was another SFA occlusion, and we did, it was actually another a power pulse technique thrombectomy patient, and this was a combination of debris as well as some thrombus, and we had distal embolization despite using a filter. So both of these cases actually had filters. So just because you have a filter doesn't mean you're completely protected, because sometimes this debris can go past the filter. But I saw no reflow. I pulled the filter out, and this is what I saw. And so we put the Penumbra device down, aspirated back, and again, this is after one insertion, and that's what we got out. It's pretty incredible to be able to do that quickly, that easily. And again, there are other options. You can use a filter, you can use other things, but it does put you at risk of further pushing that debris down. Other options in these situations can also be stenting, but again, now you're leaving something behind, especially in the below-the-knee vessels. You probably don't want to, especially if you can do something like this and actually remove it. Balloon angioplasty is always the wrong answer. It's never the correct answer, because you'll pretty much either push that down, or you will just push it up against the vessel wall. Then when you deflate, it's just going to come right back. So in summary, complications will happen. Expect it. The important thing is knowing how to deal with it. And once you know how to deal with it, then you can improve patient care and improve patient outcomes. Distal embolization from atherosclerosis can be absolutely devastating. Know how to get out of trouble. This is probably one of the most devastating things that can happen in your endovascular practice, especially if you're doing a lot of atherectomy. It can happen. The Penumbra device, I believe, is an essential tool in your toolbox and should be first-line therapy for atherosclerotic distal embolization. Thank you.
Just a quick question. What is the internal diameter of the device, or of the catheter, again? 1.67. Okay. And it doesn't taper down? It doesn't taper. Okay, so you can imagine this going down and the edge creating some sort of a cheese, creating effect on the inside of the vessel. How do you prevent that as you're advancing it over the wire?
I'm sorry, say that again. How do you prevent what?
When you are advancing the catheter down to the proximal edge of the thrombus to suck it out, because it doesn't taper down, there's the possibility that that edge can catch on the wall and sort of shear off more stuff going down.
I see what you're saying. So the question is can the catheter itself shear off
Correct.
part of the artery? So again, you're going to use the right device for the right size vessel. So for SFA and popliteal arteries, you're going to use a Cat5, which is a 1.67. Remember, a popliteal artery is going to be between 3 to 5 millimeters. It's not going to be 1.67. Now, let's say you're using a Cat5 in a dorsalis pedis artery that's 2 millimeters. Yeah, you can have that problem. So that's why you have to make sure you use the right device for the size of the vessel.
That's actually a very good question. I'll speak to that a little bit. These devices are actually originally made for going all the way up in the cerebrovascular system and aspirating. So the very tips of them are extremely soft and really aren't going to do much damage. There is a taper, but it actually tapers backwards. So the lumen gets bigger, creating more suction. So imagine, I'll show you some images, but imagine going all the way up to the basilar artery with these devices, sucking out clot. You should be able to get all the way out into the hand, all the way out into the tibial vessels. So I'll talk to you about a little bit the history of Penumbra, some cases as well, and how we've utilized it. It's a great honor to speak in front of this crowd. There's a couple people in the front row who are true experts in thrombus management, Dr. McNamara, Dr. Lynn. So we'll talk about this. Any questions that you have? Yes, Amir as well, and I'll show you some images of Winkie's brain here in a second. So what's the quest for the ultimate stroke device? And this is really where Penumbra started off. And it's to open up arteries quickly, remove the thrombus intact, and make it a safe, simple procedure and make it very economical. I'll give you a perfect example of this. There was a patient in my institution who had clot go all the way up to the basilar artery. Some of that shot off into the hand and the brachial artery. The neurointerventional radiologist went up there. They called both of us. Called me for the hand, called him for the brain. By the time I got there, he asked me just to check the pulse because he'd sucked out the clot out of the basilar artery, and while he was there, he went down the subclavian, sucked out the clot, and just wanted to make sure the hand was okay, and it was. So it's actually very quick. This is actually Winkie's brain, the one on the left, not the one with the sands of time. But you can see there he doesn't have much in the way of a posterior circulation. That's why if you've ever seen him play golf, he's very, very clumsy, and he's not very good with lining up his putts. But you can see here that there is some clot there in the basilar artery and in this posterior circulation. You have to get up there relatively quickly to remove that clot. And here, this is the image after going up there with that device, removing that clot, and now you can see marked improvement in the posterior circulation. Again, here, acute stroke. This is going up with the device, pulling out the clot. The nice thing that you get with this is you can actually see what you're removing, and it removes it relatively quickly. It's a very easy setup that you saw in the previous talk. Here's the outcome with this, and again, this is relatively basically the same device that you're using in the periphery. This is the device that's getting all the way up there in the cerebrovascular. Very tortuous, acute clot, and sucking out relatively quickly without much spasm there at the end of the case. Again, you can see this area right here. You can see the clot extending out there, going up with the Penumbra device. This is what you remove. You can imagine using this out in the tibials and the distal vessels and getting out in the popliteal and the SFA. This is 30 minutes from groin puncture to TICI-3 flow. You can see here marked improvement. This is all FDA approved. It have had over 100,000 cases utilizing this device in the cerebrovasculature. So it's a fast, simple procedure. Clots removed completely. It's very quick to set up. It's very economical, and you don't have to use intraarterial lytics with this. So for the rest of us, we get to stroke in the periphery. The ischemic limb. I'm actually going to show you a couple of the cases outside the limb where we've utilized it as well. What's the problem with these cases? The use of lytics. Some of these patients are actually quite old. You have to drip them overnight. It increases the risk of intraarterial or cerebral hemorrhage, and then the other risk of bleeding complications. So if you can actually limit the amount of lytics that you give and or not use them at all, there's probably some potential benefit. I have found that most of the time when I have to use some sort of mechanical aspiration device or some sort of thrombectomy device, I find that most of the time the adjunctive use of lytics is usually quite helpful. However, in these cases, I found it actually works quite well even without the use of thrombolytics. That's really why I've gotten on board. Surgery certainly has its options as well, and as a surgeon, I do embolectomies all the time. But you know, it's sort of a long, drawn-out procedure, and this sort of avoids the incision. You have a variety of other aspiration catheters, again, usually only for soft or acute clot with limited trackability. That's sort of the question that you were asking. This is a very different catheter that you need to take a look at. Mechanical systems, i.e. angiojet, utilize it, but it does have a sort of a high risk of distal emboli, risk of renal complications if you go over using too much volume. And it also can be, while it used to be an extremely bulky setup, they've made that simpler, but this is a setup that's even more simple than that. This is the actual device, so there's the catheter. It actually has a separator, which is which is not much bigger than your standard 014 or 018 wire, but it's actually extremely helpful in removing the thrombus because it sort of breaks it up, and you can actually use the device to track over that wire. There's two devices. There's a Cat 3 and a Cat 5, just different sizes with bigger aspiration lumen in the Cat 5. This is actually how it works. So it's set up. Hopefully this video is going to play. It's set up to that system that he showed you in the earlier talk. You just put the device here. Again, you want to go slow. That's the aspiration. There's a very small olive on the tip of that. And you basically just sort of push that wire with that little olive there, and that helps break up the clot into smaller pieces. You even saw it where it's sort of behind the catheter, and then it sort of sucked up the clot right up along and into the catheter. With really going slow, starting proximally and going distally, you suck it out, and then you decrease the risk of distal embolization. This is a case from the guys down in Miami, Baptist Vascular Institute, Benedetti here. You can see here some clot down at the distal popliteal, down in the anterior tibial-perineal trunk with sort of slow flow through there. And you can see here taking down the Cat 5, sucking up all that clot, removing, and then getting very nice runoff without any risk of distal embolization. No lytics were given there. My previous partner there at Stanford, Sean Samuels, again, you can see here, patient presented with an ischemic limb, went down with the Indigo device. You can still see there's probably some clot still there in the anterior tibial, but again, down the tibial-perineal trunk, he sort of opened all that up and sort of improved the distal outflow. Still some clot going down the anterior tibial there, like I've already shown you, but now he at least has flow getting down into the posterior tibial. Even if you're going to use lytics in this case, by getting that clot up and getting blood down there, this is going to probably shorten the amount of thrombolytics that you have to get. Again, another case here. Again, can you use it in bigger vessels? You can see here that there's clot up in this recanalization of the common femoral, right there, kind of right at the femoral bifurcation, went in with the Indigo, no lytics were utilized, and then sucking that out. This is that sort of case at the end where you've sort of done a long procedure. What do you do with that stuff that's sort of sitting there? Do you balloon it? Probably not the best idea. Do you go in there using angiojet? Do you give some lytics? Do you just let it sit there and then treat them with anticoagulation post-procedure? This device is so easy to set up that it doesn't take much to sort of get it in there and take it out. Again, you can see here recanalization of the popliteal TP trunk. You see a large amount of clot down there in the tibial-perineal trunk extending out in the anterior tibial. Again, no thrombolytics were utilized, and you can see a very nice end result there at the end of the case. This is a patient that I utilized it in. I've actually done this in two different patients. One a diabetic with a gangrenous hand, who sort of had severe ulnar and radial artery disease, really didn't have much in the way of the flow. I thought he actually just sort of acutely shut off his hand. Basically balloon angioplasty, the radial artery as well as the ulnar, and then went down all the way out. This is actually all the way out into the arch of the hand, removing that, and was actually able to salvage his hand. Recently did one as well with a patient who had hypothenar hammer syndrome and had an ulnar artery, and basically clotted off, came to me with 3 ischemic fingers, sucked it all out, gave him some lytics all the way out into the digital vessels, but was able to actually salvage his hand as well. This is a patient of my partner's. Patient came again with an acutely ischemic leg. You can see here not much in the way of flow going down into the tibial vessels. I was able to actually suck that out, and the patient did quite well. This is a patient that I actually just did about, probably about 2 weeks ago. He had a juxtarenal aneurysm, was referred to me for a complex aortic aneurysm repair, stents placed within this right and left renal as well as in the superior mesenteric artery. It was not a candidate for open surgery. I elected to treat him utilizing a variety of different techniques with parallel grafts. And at the end of my procedure, I shot everything, and everything actually looked good. So I take a look at each of the visceral vessels, and you can see there's his superior mesenteric artery with an abrupt cutoff. Now, this is a case that probably I've already been in there 3.5 hours, and now I've got a guy who's actually doing well on the table, but it's sort of hard to just leave that alone. At that time, I've got a cut down on one side. I don't want to be injecting a bunch of thrombolytics. I certainly don't want to cut down and do an embolectomy on that case after 3.5 hours in sort of a hybrid room. It's sort of a wide table. It's going to hurt your back as a surgeon to have to bend over that. That's going to be another 2 hours. I actually already had a wire down there and went down actually with the catheter. Here you can see thrombus down that digital branch. Went down with the Cat 5. Actually sucked that out. Again, here you can see that sort of abrupt break-off with the actual thrombus. You can see it down there. That was sort of one pass, so I sort of cleaned it up quite nicely, but I still have some stuff down there right at that bifurcation. Went down with another pass, and now you can see my runoff is actually nice, clean, nice, wide open. This patient actually still did well and was discharged home 2 days later. And that really saved me a lot of time and a lot of hassle and really prevented any sort of catastrophic complications with regards to mesenteric ischemia for that patient. So this is what you get when you utilize the device. You can utilize it if you're aspirating following atherectomy. I don't do that much atherectomy, but again, we do manage a fair amount of clot, and you can see this is the sort of clot that you're going to remove with this device. And again, this is really without the use of any sort of thrombolytics at all. So it gives you a very nice endovascular option for clot management that's very safe and simple procedure. It really reduces the need of the use of thrombolytics. I still use thrombolytics, but I don't have to use it all the time. And you can actually take a look and see what you're taking out at the end of the case, and it's a fairly economical procedure as well. Thank you very much. Oh, sorry. I'm not done. I forgot. This is a talk for Penumbra, and they have another device, which is the coil, and it's so I just open up blood flow. Now I'm going to shut it off utilizing the coil. This is a coil that's actually very nice. They come in very large sizes, so you can have a 20-60 coil. I do a lot of large vessel closures with these devices. It saves me a lot of times. It reduces the number of coils. It has a very nice, reliable, and quick detachment system that gives me a lot of control. It's much larger than the other detachable coils. Most coils are based on the size of the catheter that you put them in. These ones are actually bigger than those other coils. You can see it packs very densely, very nicely. It comes with a compatible high-flow microcatheter with a variety of different angles and shapes. It's got a very, very nice detachment system that's very, very quick, and it's a true detachment system that once it's out of the catheter, then you can detach it. You can see just how nicely it packs compared to a conventional detachable coil. It packs very dense, very quickly, and it coils really nice and soft. The detachment system is what I really like. It's a instant one-click detachment, which is very precise and very consistent with its handle every time. These are just a couple different procedures. You can see here, this was actually a ruptured internal iliac artery aneurysm. Patient was not doing well. He was hypotensive, and I actually just, typically I would, on something like that, I would get into each of the individual branches. I just didn't have time to do that, so I just packed it full of these coils. This is 348 centimeters of coils delivered in less than 10 minutes, and then I put a stent graft over the orifice, and he actually did quite well. You can see just how nicely this coils and how accurate these coil in the subclavian artery, where I'm trying to get it right up to that vertebral artery so I don't create any sort of gutter with emboli extending up. And you can see how nice it packs. So even with a Amplatz or plug, where I think you can get some, or I've had some recanalization in the left subclavian, I can pack this nice right up against the stent graft and be very accurate. Again, just a type 1 endoleak sort of retrograde. Had retrograde filling up from a AUI that I put in and just shut that off very quickly. Thank you very much.
We have any questions from the audience? Yes, sir.
What are your thoughts? You're no expert with management of thrombus. Utilize most devices.
I think it's very attractive. I think anybody would want to get their hands on it and manipulate it. Is it a one-time use as far as the pump is concerned? When you buy it, you buy the catheter and you buy the pump, or?
The catheter itself is a one-time use. The catheter itself is a one-time use, but the pump itself is can be utilized for all cases. So it's a one-time buy on the pump, but the catheters themselves are not reusable.
Is the pump substantial in cost? You'd have to go through some committee to...
You know, the pump was already there when I started utilizing it because the neurointerventional radiologists were utilizing it. So I don't know the actual cost of the pump. Do you?
But I think it would be different for every company and every hospital, and they have different deals, and you can get the pump for free if you purchase a couple of catheters and things like that. So I'd probably just talk to the company and see what they, sort of their, how they would approach that.
So how do you get it there, though? You use a small wire?
Yeah, I usually track a wire all the way down to wherever I want to go, and then the device will actually track over a wire. There's a TUI on the back that you just tighten the TUI at the end, and then that creates the aspiration. And then if you use the dispersion wire that sort of breaks up the clot, you can still move that back and forth and still have a seal on the back end to where you get the aspiration.
And it doesn't have a central, you know, like a dilator within it. You just pass it down open mouth like it is over the wire.
It just passes down open mouth. Again, if you take a look at the catheter tips, these catheters were originally designed to go all the way up into the cerebral vasculature, so they're very soft, track very well through tortuosity. So when you're going down through the periphery, most of those vessels are fairly straight, so it tracks really no problem.
And it's, I kind of miss what were the advantages of using the pump as opposed to just aspirating mechanically by your hand.
So I had a slide that described that. So when you have manual aspiration, what happens with the vacuum is that it initially increases, but then as you aspirate back, it goes down. This is a consistent, pretty powerful vacuum, so it consistently vacuums throughout the entire time that you have the machine on.
And you start at the proximal end and just
Proximal and then
scoop
go
it.
distal, yeah.
You get greater aspiration. The amount of aspiration that you get is higher with the pump than with just manual aspiration.
I see. Good. And have you had it where the clot fragmented? Probably this system partially occludes flow, so you don't have flow there to wash little air particles downstream. Once you've largely debulked it, the last little bit doesn't disappear further downstream.
Right, in the small vessels, it basically should occlude flow, which is good, because then you just go slow and you just sort of break up the clot and suck it out. That's basically what it does in the cerebral vasculature system.
Great.
And when you have atherosclerotic debris, it does occlude flow as well, and that's when you know to pull it back. And so as it occludes flow, you keep the system on, and then you pull it back while it's on, and then it just sort of has it right at the mouth, and you can completely remove it.
Great.
Do you initially use manual aspiration, and then if that doesn't work, do you then bring out this system? Similarly, are you using angiojet anymore, or is this your first line agent?
So for angiojet, I don't use that anymore for distal embolization. I've never used it for distal embolization for debris because it just won't work. For thrombus, you can use it, but this is just so much easier to set up and so much quicker. And but that is another option, is to use angiojet for thrombus, but not for atherosclerotic debris.
Yeah, I mean, I still use angiojet as well, because there are certainly vessels that are much larger than the size of these catheters. So in those instances, angiojet may be your better choice. However, this company is very forward-thinking, and they're certainly moving in the direction of treating larger vessels, including for patients with DVT, and aspirating this clot out.
Yeah, that was going to be my question. I mean, the principle is simple enough and very applicable. Do you foresee the possibility of this being used in the pulmonary system for like an acute PE?
Yeah, they're working on those devices currently as we speak, both for, again, DVT as well as pulmonary emboli. And again, the device is so soft that tracking up into the pulmonary vasculature shouldn't really be much of a problem at all.
Frank, it looks good, whatever limited series you have. And all with thrombus sucking devices, we have also noticed the distal embolization. So is there a significant amount of distal embolization, or the incidence is less compared to other devices?
You know, I certainly a guy that believes in data, and I don't have much data to support one way or the other, but in my own experience, I have not yet in the way of had any distal embolization with this device. Now, again, I tend to go slow. I tend to start proximal, go there, watch it. I use the dispersion wire to break it up, and then I just track it real slow. And even if it does embolize distally, you know, I'm already going with my devices. I've already been all the way out into the hand, all the way out to the very pedal vessels with it, aspirating clot from things that have embolized, or trying to open up things in a critical limb ischemia. So I'm so far down there already that I really can't embolize any further.
Yeah, and again, this is one of those devices that you really don't want to use because it means that there's a problem and there's either a complication or an adverse event. So there's small series. I've used it probably 3 or 4 times. I think all of us that have used it, we kind of, try to share ideas and thoughts about it. I think if you have any questions, maybe we could ask our reps over at the exhibit hall, and they can answer any further questions such as that. But with that, we'll go ahead and move on. And also, if you have any questions about the Acera device, they're also in the exhibit hall, and I encourage you to visit them as well. Thank you so much for the lunch symposium, which is sponsored by Penumbra as well as by Acera. And we'll go ahead and start with our afternoon session in just a little bit. Yes, sir. Is it going to be a golf?
The posterior circulation has nothing to do with the golf game.